to the session. Hopefully that energized everybody a little bit. At StartUp Health, we're all about bringing energy to founders and entrepreneurs and to tackle the problems that we're facing in healthcare. I'm going to start off to my left. André, please introduce yourself and your moonshot mission.
Hey, thanks, Jamey. Thanks for being here. So my name's André Diamant. I'm the CEO and founder of Gray Oncology Solutions. And really what we're looking to do is standardize, optimize, and automate the way that patients move through their cancer care trajectory. So break down all the silos, whether it's infusion, radiation, pharmacy, lab work, imaging, and make sure that as health providers, we're looking at that trajectory from the patient's perspective, from A to B to C, rather than individual silos. So just really ensuring care trajectories are standardized and that operations and strategic planning is as efficient as possible.
Thank you, André. Fox.
Fox Holt. I'm the CEO of Vigilant Software. Vigilant is on a mission to help hospital clinicians stop medication errors. We hope to eliminate medication errors in hospitals by providing automation and predictive analytics regarding safety procedures when they deliver drugs.
Thank you, Fox. Sanji.
Hi, Sanji Silva, Chief Product Officer, leading both product and engineering at Mocingbird. At Mocingbird, we are on a mission to improve clinician wellness, and we do that by automating the credential maintenance. What's unique about us is we were clinician co-founded. So what that means is at the heart of every product and design decision we make, we keep the clinician user experience in mind. Plus, we have an actual technology solution that's backed by a SaaS platform that's backed by a sound technology solution with an algorithm behind the scenes versus just a facade, which sometimes you see with software products out there.
Thank you, Sanji. Patrick.
Patrick Bradley. I'm the co-founder and chief clinical officer of Kinometrix. Kinometrix is on a mission to eliminate patient harm in the hospital. And we do that by using machine learning to transform the risk assessment piece, a piece that's really oftentimes missed or overlooked in hospital acquired conditions. And we're starting with patient falls and really redoing and revamping the way that patients are assessed for risk for falling to better identify why, and so they can intervene appropriately for those patients.
Thank you. So hospitals and health systems aren't known as being typically the most progressive organizations on the face of the planet. Healthcare has that, basic a tenet, if you will, where we're not considered as an industry to be very forward-thinking, and I think we've seen that changing. But you guys are all innovating in the health system space. Can you tell us where you see the greatest room for impact, the greatest room for improvement? And Sanji, maybe we start with you on that one.
Yeah, absolutely, Jamey. So when I talk to any clinician about continuing education, they segment it into two buckets. One, what they have to do, the requirements that are mandated by credentialing bodies. And the second bucket is what they actually learn to do better at their jobs, to treat patients better, to improve medicine. There really shouldn't be this gap when it comes to continuing education. So where I see the most work left to do is if there's any paperwork or administrative work as part of the workflow that doesn't require clinician interaction or clinician care, it must be automated. And it can, right? So that to me, as a technologist, it's a really exciting time to be alive. We all hear about ChatGPT, OpenAI. I really think we're at the beginning of a revolution, and we need to help our healthcare providers more. I won't bore you with stats, but there's the labor nurse who helped me last year as I birthed my son. She was my cheerleader for hours and hours and hours. There's the OB who decided at 4 hours of pushing that was enough. It was time for my son to come out and see this world, right? These are real life heroes, and we need to give them the time back to do what they got in to do, which is care for the patients. But today, 2/3 of their time, of doctors' time, of nurses' time is spent doing administrative work, 2/3. And it's so severe that they call it pajama time. So we have to come together and make this better. And we have the digital tools to do that.
Patrick?
Yeah, I want to agree with that. As a nurse myself, I can say that what clinicians want to do is meaningful work. And the more we can utilize AI and machine learning and these tools to transform their workflows so they are able to do what they got into this world to do, which was care for people and not spend time documenting or doing those administrative tasks. With our model, for example, we took away something that seems pretty simple. It's a 2 to 3 minute fall risk assessment. Well, that 2 to 3 minutes gets multiplied across 5, 6 patients if you have that, and 15 minutes matters to a nurse at the bedside. And what they can do with that 15 minutes back, administer medication, hold the hand of their patient, take one to the toilet, whatever it might be, gets them back at the bedside. And we take what they're already doing, which was their full assessment, which is really what a nurse is there to do, is assess a patient and make a plan of care. We take that assessment, we actually put value to it by using that to already identify what is going to put them at risk for falling, and then help them then do something with that.
So an interesting notion that we talk about in a healthcare system, we really want to be patient-centric, but maybe what we're talking about is actually being a little provider-centric as well. Restore the joy of calling back to the clinical team so they can do what they initially wanted to do when they were coming out of medical school. Fox, where's the greatest room for improvement?
Jumping on this bandwagon, it's that busy work. For example, Vigilant is helping clinicians, like specifically ICU nurses, with IV tube labeling. And there's no patient information here, and so it's even lower hanging fruit. We don't have to go through any PHI processes, and it's very impactful, right? Nurses hate handwriting on the small labels. They hate mentally calculating expiration times, and so it's also part of this busy work realm. And by automating these steps and by providing the information at the point of care that's so critical, it makes a huge impact. And it's really low-hanging fruit from an automation perspective.
André, bring us home.
Yeah, certainly echo what the others have said in terms of automation. To add to that, and I think an issue that also causes a lot of busy work, as you say, is the fragmentation. Just how fragmented all of these individual silos are really forces staff to call back and forth, play telephone for some patient between medical oncology, radiation oncology. When's the appointment going to be? Make sure we're not double booking them. Make sure it's connected. We don't want them to have to travel too far, so on and so forth. And all of that work is just added on because of how fragmented the entire system is. So in addition to automating a lot of those tasks by making an attempt to defragment the care trajectory, it in itself will free up a lot of clinical time.
So I'm a little famous for going off script, and I want to just go down a thread that was mentioned here in the panel. So McKinsey basically said there's $250 billion of digital transformation opportunity in healthcare. Right? That's a big number. How do you make the opportunity a reality? You are sitting there with health systems. How do you get them to go and adopt your service? What are the tactics that you're using? How are you finding champions? What does that process look like? Maybe, Sanji, we can start with you again.
Yeah, absolutely, Jamey. The sales cycles are long, long, long. Nobody is, it's no surprise to anyone, but starting to build those relationships, start early. It can take, we have our chief revenue officer here, and it took us 25 months to close one of the deals. That's how long it takes. So, but also we have a solution, so we have a platform that's actually clinician facing. We do have a B2B strategy. However, we have made it possible, if a clinician finds Mocingbird, they can onboard themselves and use it. And we also have made sure that for continuing educations, usually clinicians get a stipend to spend, a couple of $1,000s. So we've made sure that our platform can be reimbursed. So that, again, is just removing all those barriers and really trying to get clinicians using the product. And now we have internal champions who then make it that much easier to go kind of at the health system level and get the product into more clinician hands.
Fox, why don't you follow that up? I mean, how do you ensure that you're moving from opportunity to adoption?
Yeah, we spend a lot of time looking at the friction of the sales process. And so we have an entry-level product that helps automate workflows that doesn't need to interface with IT. IT seems to be one of the major hurdles. And so not having to deal with IT, having that product initially be underneath capital budgets. So a nurse manager with her operating budget in 30 days after a free trial can make a purchasing decision and put it in their unit. And so, having a sales cycle that's 45 days and just constantly trying to help that nurse manager not have to do much of the sales process, providing with the surveys that they are able to provide, understanding, what metrics they need to be analyzing for their value analysis committees, and making it tremendously easy to have all that written up and just have it locked and loaded.
André?
I would say collaboration and co-development. I'm going to take more of a product focus on this. From the start, from the ground up, a product philosophy of build software that people actually want to use. A lot of, not just healthcare software, but a lot of enterprise software, people don't want to use. They're kind of forced to use it. It's not enjoyable. It makes their life harder. It adds anxiety, busy work. So we've really tried to build software that people actually want to use. It's going to make their life better. So then when we're going through all those steps and getting all the stakeholders involved, which is a necessity in our case, unfortunately, we can't bypass IT. At the very least, all of the users, we want to get them excited about using it, as opposed to having sort of internal resistance to yet another software. So to try and take a different approach to the question, I suppose.
Yeah, so an important point. I can't tell you how many times we see founders who are going out with products that they think they've developed for all the right reasons, and they end up getting to market and realize the product they built isn't the one the market needs. So I think that's a really key and critical point. Patrick?
We definitely have to deal with IT, so there was no way around that. So our sales cycle is longer, but it was really important to us with that we did not create anything that added any clicks to the nurse. It was vital that how our system works is it reads and writes right back into where they currently see in their normal workflow a fall risk. That we are not going to create a dashboard with any fancy analytics, that they would see any numbers. It was just going to show up, give them what the information they needed to know, and prompt an action. And that was really key for us, and that is, speaks to the nurses that we speak with. Our primary customers are chief nursing officers or chief nursing informatics officers. And, I mentioned before the time saving, and not for nothing, the obvious one is reducing patient falls, which is, I haven't found a nurse yet that it's not a pain point for them that their patients continue to fall in a hospital. But then there's a resource management piece. The reality of our current fall risk assessment and why we went the route we did of really honing on risk assessment is that our current fall risk assessments generally tell you about 55% plus of a diverse patient population will be at a high risk for falling. No hospital has the resources to implement true interventions across more than half of their patients. So we give them not only that data that they need, that information, but we reduce the number of people that are trying to do this with because we hone in on what's going to work for each individual patient. And that was really what we needed to focus in on, and that's what speaks to our customers.
So an important point, and Sanji, then we'll go to you, which is that hospitals are really focused on platform now and not point solution from that perspective. And if you can integrate into the current platforms that they already have, really important to not teach a doctor a new bag of tricks, but to let them leverage the existing workflows that they have to be successful. Sanji?
Yeah, and I just want to add on to what Fox said about reducing barriers. Security is another hot topic. I know we've been talking about it at ViVE a lot, but even as an early digital health solution, it's important to get your security straight. And just so we went ahead and got our SOC 2 Type 2 compliance worked on last year, and that is now one less thing. It gives you credibility. It gives you, health systems are almost also kind of testing you to see, hey, will you be around? Can you do all of these things as a newcomer? So that I would say is another huge piece. If you can get the SOC 2 done or whatever certification for security.
So COVID really laid bare the seams of our healthcare system. And if you didn't have a health equity initiative prior to COVID, you certainly do now if you're a health system. Patrick, can you talk about how you play into the health equity strategic imperative that these health systems now have?
Sure. I'm an AI optimist in that sense. I'm with you on that. It's a really exciting time, and I think AI and machine learning, when used correctly, really gives us a chance to embrace health equity. And in my world as a clinician, health equity means bringing the care that each individual needs to get them to the health optimization that they need, not at one size fits all or anything like that. And the beauty of machine learning and artificial intelligence is you can really hone it to look at objective data and be as objective as possible. And if you are building a model that is objective, then you don't have that inherent bias that where we've seen the stories of machine learning going wrong, it's generally when human bias gets introduced into it. And so while fall risk assessment might not seem like something that is really a health equity boom, but how we built our model is entirely objective data. It is not going to prioritize any race, creed, color, anything like that, or it's going to say, what does this patient need based on what's going on with them, and direct it to that.
Sanji, do you have any thoughts on your solution in health equity?
Yeah, Jamey. So the previous panel talked about cultural competency, for example. And one major factor they talked about is education. So we are trying to make sure that clinicians can consume relevant and high impact education. Because today, unfortunately, CME requirements are kind of checking a box. And sometimes clinicians just go back to the same course to keep take it over and over every year because they know it meets that requirement. And that's where we come in and we do the vetting, because from state to state, all the requirements are different. And more, especially with telemedicine and how we know it's effective, we see more clinicians having 50 state licenses. And when these requirements are all different across the board, it is impossible to keep up with spreadsheets, with administrators. So this is where we come in and we make it very easy. You enter all the credentials, you get a dashboard that tells the clinician exactly what they need to do when. But additionally, what we're launching this year is a course recommendation tool that now is going to recommend courses that not only will meet the requirements they have to do, but will learn what's the specialty, and be able to recommend courses to the clinician that would actually be impactful for their patient care. And that's kind of our longer vision too. Long term, we want to be delivering real time as clinicians are practicing education that's relevant.
So Sanji, you just mentioned impact. Maybe André, we can start with you. Clearly measuring ROI of your solution at a hospital or health system, or figuring out what the impact is, the KPIs that you're measuring, how you're going to show success is a key part of adoption. What are the KPIs that are really critical for you when you're working with a hospital or health system partner?
So there's a few of them, and in no particular order, because I wouldn't say any is more or less important than the other. First off, we look at administrative burden, staff satisfaction, reducing that grind, that monotonous task, giving them more time to be freed up for high value add clinical tasks, spending time with patients, reducing that, making sure that's cut significantly. Secondly, reducing patient delays, making sure we're getting patients through the door quicker, making sure there's no delays in the worst case falling through the cracks of their radiation treatment to their chemo treatment or any follow-up care, so on and so forth. And then finally, just a raw access to care of if we're helping health systems be more efficient with their resources, they can do more with less. And anytime you can treat 105 patients with the same resources that yesterday you were treating 100, that's 5 patients who are getting treated quicker and may not have to go elsewhere for care or jump through hoops to figure out how they're going to get the care when they need it.
Fox, how about you? How are you proving your case study in a sales deck? What are you pointing success looking like for your product and solution?
Very, very similar to André. We look at a lot at nurse satisfaction, clinician satisfaction. In the surveys that we give nurses and nurse managers, we see 75% increases in nurse satisfaction around drug deliveries, efficiencies of the staff. So, saving 4,000 hours for an average critical care unit. And then lastly, compliance. Compliance is obviously somewhat a indicator of patient safety, but those are really the 3 metrics. We see 40% increase in compliance as well. So just helping them realize those through trials is pretty impactful.
Sanji?
Yeah, I echo everything Fox and André have said. It's the time saved for administrators, the credentialing managers, credentialing directors who are doing this work. No joke, we have a client where, we know they print out the transcripts and highlight what is relevant to stroke, for example, and circle things. And this is what's still happening out there today. So one cool part of our platform is we have the rules and the requirements engine, but we also tell the clinician, just take a photo on your phone app, we have a phone app too, or upload a PDF of your certificate for the CME you took or the conference that you went to. We have a way to extract that data through an OCR AI model and automate that. Now, it's not as simple as it sounds because no two certificates look the same, so we're still improving that. We're working on, the good thing is we have tens and thousands of files now with the growth we had with users last year, and we're peeling the onion and trying to build that data set, the mapping with kind of keywords and the knowledge from our clinicians to say, oh, for stroke, what are some of the other words and other topics that actually meet this particular requirement, right? Because today, a lot of that knowledge is dispersed and sometimes in the minds of these admins, the credentialing admins who've been in the industry for 20, 30 years, but it's not scalable, right? So,
Patrick, how are you measuring impact?
A few key things. The first and foremost is hospital-acquired conditions and reduction in patient harm, and that's publicly reported for every hospital, be it through Leapfrog's hospital grade system or CMS Hospital Compare. You can go on and see your hospital, your local hospital's performance on anything from falls with injury to venous thrombosis, things like that. So that's first and foremost. But second with that is did we help you reduce that resource utilization to do that? If we told you less patients are truly at risk for fall and told you why each individual was at risk for fall, how did that impact your resources that went into intervening? And last but certainly not least is our clinician satisfaction with it. Are they happy with the interface in their EMR and EHR and how it prompts them to do different work?
So at StartUp Health, we talk a lot about moonshot missions and their importance. What specifically are you targeting this year to get done? Right? What's at the end of the year, you're going to say, I'm measuring success in this way with my own company. And then why are you here at ViVE? What can this audience do to help you achieve that moonshot mission? And maybe Patrick, we'll start with you and come down the line.
Sure. Kinometrix is piloting with several large academic health systems. We hope falls is not something you fix overnight. We want really good, robust data. We're looking at 12 months of data minimum, so it's a long cycle. But at the same time, we're still looking for more health system partners, innovative health systems that want to bring this in and really test it and make it work for them. And our next solution will be focused on pressure injuries. So we're looking for someone that's a pain point for them and wants to partner with us in developing that.
Sanji?
Yeah, so we are, again, I mentioned this before, we're launching a course recommendation tool. We're working on further automation. What I would say to the audience is if you are playing in the credentialing space or licensing space, we believe in partnership. We didn't get into doing the credentialing work because we knew there are plenty of other great products out there, right? But CME comes right after the credentialing, and that's where we have partnered with Certify OS, and it's not just a partnership. We actually have a back-end integration, and we're open to doing that with more and more credentialing tools, because again, that just takes away double data entry for administrators, so that they can be focused on other things. And similarly, for health systems, there are many examples. They don't get publicized as much on the news, but clinicians and health systems get caught off guard because these requirements, sometimes it's a very specific mandatory human trafficking course that the state says you have to take. But a clinician might be like, oh, I took a course on human trafficking, and they truly believe they meet the requirements, and it's good intentions, but unfortunately they didn't do exactly what the state required, and now clinicians can be audited going back 3 cycles. That can mean 6 or 7 years, and there are cases where health systems got fined and had to put corrective measures in place, And there's lost revenue there too, as these clinicians are now not able to practice, right? So don't wait, be proactive. We're helping on that front to not waste money, right? But at the same time, it's also a clinician engagement tool. It helps the clinicians to keep track of this. So really, health systems, come talk to us, and let's find how we can work together to help our clinicians.
Thank you, Sanji. Fox?
Product awareness. We're in 18 of the top 40 health systems right now, but we've got a lot of systems left, and we really need to get in front of nurse management, any health system or hospital where you have nursing shortages or burnout issues. We'd love an introduction. We'd love to get in there and help. We are trying to close a round right now. We're $500,000 away from closing our round. So any investors out there, we'd love that help as well. But mostly product awareness.
Well, congratulations on that, and what's a tough funding market. Almost getting that across the finish line. We know you will soon.
Thank you, thank you.
Yes, André.
Yeah, to work backwards, to echo what everyone said about product awareness, really just looking for health systems that want to transform the way that they think of logistics, and particularly if they have multiple physical locations and are really thinking of how can I make sure that care is coordinated from each of these physical locations, triage patients to a particular area based on that patient's location. These are all elements that our software allows for. And then this year, a real big focus of what we're looking to do in the next 12 months, I mentioned how we help standardize care trajectories, and we really give sort of a rich digital representation of the care trajectories that move through the system. We're now looking at ways that we can be more prescriptive in that information rather than just diagnostic, and we can show those care trajectories and then highlight where there may be differences from standard of care. If there's particular elements where, the system is giving too many early stage MRIs to early stage breast cancer patients, which go against NCCN guidelines. These are things that we can help try and highlight and see if there's any ways you can improve whatever your standard of care actually ends up being.
So I'd like to thank our panel. You guys have heard from them first of ways to collaborate and partner. We're really proud of these founders. If you want to meet with any of them, the StartUp Health booth is right up over there. Please come and do so following the session. If we could give a round of applause to the founders. Thank you guys so much for the work that you're doing.
Thank you.
Thank you.
Everyone enjoy the rest of ViVE.